Hi there, I'm Julie Kenville, president of the MUHC Foundation, and this is our very first episode of Health Matters. Each week, I will take you behind the scenes with leading experts to discuss today's pressing medical issues and to find out how we're changing the course of lives and medicine right here in Montreal. Today, we are joined by Dr. Vinh. He's an infectious disease specialist, a clinician, and a researcher at the MUHC. He is often referred to as the Canadian Dr. House for his work in rare genetic disorders. We're also joined by Dr. Veronique Naessens. She is a clinician and a researcher in hematology at the MUHC. Welcome to both of you, and thanks for joining us on Health Matters.
Thank you, Julie.
Thank you. Hello.
So today we're going to talk about COVID-19, and of course it has greatly affected our lives, our work, and it has killed more than 650,000 people worldwide. But before we talk about COVID-19, we'd really like to hear from you on what work you did at the MUHC, what kind of clinical and research work you were doing before the pandemic hit. And Dr. Naessens, maybe we'll start with you today.
Sure. So as you said, I'm a hematologist. I've been working at the MUHC for 6 years now. I work mostly in the adult field, and my specialty is mostly on benign blood disorders. So anything that's not related to cancer. So anything that can include blood diseases such as disorders of the red cells or bleeding problem or clotting problem. So my niche is truly in that field, and I'm doing a bit of research in red cell disorders such as sickle cell disease and thalassemia. And I obviously have resonance and a great academic and teaching portfolio with me at the MUHC. And my work before COVID was busy in terms of clinical care, teaching, and clinical research.
Well, that we should definitely invite you back on this show to talk about those areas of care. And Dr. Vinh, can you tell us a little bit about what you were working on?
So I'm a clinician scientist here at the MUHC, like you mentioned. As a clinician, I'm an infectious disease specialist. I'm also a medical microbiologist. And as a scientist, I'm what has been called a gene hunter. So what do I mean by that is that a lot of my colleagues in my field, they study how microbes are dangerous. I focus on studying how faulty genes in the immune system allow microbes to be dangerous. And so I look for holes that are from a genetic reason that weaken the immune system in patients that make them susceptible to infections.
That's incredibly fascinating and, of course, quite linked to COVID-19. Yeah. Now, I want to bring us back to the pandemic, which is, of course, has affected each and every one of us worldwide. We've started to deconfine here in Quebec, and yet the number of cases is still relatively low. We're below 200 new cases per day. And it's hard for us to understand that because we, of course, have been told that this is an incredibly contagious virus. I'm starting to hear more and more Montrealers and Quebecers who are saying that this is drastically over-exaggerated and that the virus maybe is not as severe as initially anticipated. How do you respond to that, Dr. Vinh?
I have to say that I don't agree. I mean, the virus has undoubtedly been serious, not only in the rest of the world, but certainly in Quebec. Since the start of the pandemic, we've had about 5,700 deaths, and that's a span of about 3.5 months. That averages out to about 1,000 deaths, or about maybe 1,200 deaths a month. That's serious, and those deaths affect people's families, very much so. And they've also put a significant burden on our healthcare system because of the rate at which those deaths were happening were stressing a potentially fragile or already fragile healthcare system. So I would have to recommend due diligence and say that we need to take this virus absolutely seriously.
But has it weakened? I mean, we were initially seeing extremely high numbers of new cases per day. Is it possible that the virus throughout the last few months has weakened?
It's possible, although certainly there's no evidence of that. I think what we have to keep in mind is that there are cases and then there are the consequences of those cases. Some of those consequences are deaths, and some of them are also complications from the infection. What we're seeing now is a low-level amount of cases or activities, but the consequences, the deaths and the complications, those will only be seen a few weeks out. And so what we're seeing now isn't a snapshot of what's just happening now. It's a reflection of what we've been doing for the last few weeks, and it's a projection of what can happen in the next few weeks as well.
Well, why is it that in the United States we're seeing such high volume of new cases, but in Europe, where we've begun to deconfine, and here in Canada, the cases are still low? How do we explain that?
I think there's a lot of reasons for that, and I think it certainly doesn't pinpoint to one specific answer. I think we have to look at the group response. Europe, for example, and parts of Asia and other parts of the world were very quick in terms of public health measures, social distancing, early implementation of masks in public spaces, hand washing, hygiene. In some countries, some parts of the countries, in other parts of the world, they actually just shut down cities completely for long periods of time. In the U.S., the public health measures have not been perhaps as strongly enforced. We certainly see a lot of public activities, for example, in beaches, with disregard for public masks and probably other measures of hand hygiene and cough hygiene. And so they've never gotten their pandemic or their outbreak under control, and so that continues to rage on. Whereas other countries have gotten the bulk of the disease under control, and there's perhaps what we call the burning bush that still needs to be extinguished.
Dr. Naessens, so we hear a lot about asymptomatic cases, but yet we're also hearing about healthy 40-year-olds who end up in the intensive care unit for weeks on end on heart and lung machines. How do we explain that?
That's a great question you raise. And in fact, we're not exactly sure yet why certain people seem to be more affected than others. But we do see in retrospect from the last few months and experience that's been published in different parts of the world that most patients who end up with what we'll call severe COVID, so if they're hospitalized in intensive care or they're on breathing lung machine like intubation, as we say, these patients tend to be in the older age group or tend to have significant cardiovascular risk factors such as obesity, diabetes, and these tend to be perhaps sicker. But we're not sure yet as to explain why there's seem to be a small subset of yet younger patients that we would not expect to be as sick that still end up with significant morbidity and complications.
But who is at risk of catching COVID-19?
Another great question. Who is at risk of catching the disease? Again, it would be intuitive to think that people who are not making a good practice of social distancing, wearing masks, washing their hands, are more at risk of catching the disease. But who will catch the disease and who will end with a severe aspect, these are the risk factors that I just briefly mentioned. We would also think, and for me as a hematologist, initially at the beginning of the pandemic here in Quebec, we all obviously thought about our immunosuppressed patients. So for instance, patients who have blood cancers or who are on active chemotherapy or on strong immunosuppressants. We thought that these patients would possibly be at higher risk of catching a virus. But in fact, the experience that we have looking back after the first few months seems to show that mostly patients who have an active cancer on chemotherapy or specific patients who have had a transplant are at higher risk. But perhaps that's not the case for every patient who are on immunosuppressive medications for other diseases, such as IBD or rheumatoid arthritis.
So that's great news. It means our cancer patients are not necessarily more at risk of severe COVID-19. So, Dr. Vinh, can you please tell us what exactly is severe COVID-19?
So that's a great question. COVID-19 is caused by the virus SARS-CoV-2. And what we've seen in this pandemic is that even though this is a brand new virus that was sweeping across the world, not everyone was developing severe disease. So severe disease, the original descriptions were people who were having an unexplained pneumonia, an infection of the lungs. In those cases, a proportion of them would actually go on to having lung failure or respiratory failure where they needed to have a tube in place to help them breathe. So one of the forms of severe COVID is respiratory failure. We also know, however, that COVID, the virus, can also infect the heart in some people, the brain in some other people, or can cause a multi-organ failure, sepsis-type syndrome in other people. So severe COVID is when you have the viral infection, and then you need to be hospitalized, and you need usually intensive care to help you overcome that disease.
And what is the basic treatment today?
unfortunately, there is no accepted treatment yet. Certainly, we know in the news that there have been different types of therapies that have been supported or recommended by certain people, but the scientific basis for those treatments have actually been debunked. There are some medications that target the virus that are in advanced clinical trials, and they're very encouraging. They give us hope that some of those drugs can actually be used to treat COVID. And there are other types of medications that are trying to look at boosting the immune system to try to fight off the virus, and we're waiting for that data to come.
But it sounds like the virus is much more like an immune deficiency bug than it is pneumonia or what we thought it was initially, is it not?
So what's interesting about this virus is that if the virus infects a group of humans, we know that there are some people who will develop no disease, the asymptomatic. We also know that there are some people who will develop moderate disease, they have a bit of symptoms, they'll recover. And then we have these other groups of people who have the severe disease. So this variability between individuals, despite the fact that they're exposed to the same virus, tells us that there's a human component to how we handle the virus that determines what happens with disease.
What I find most impressive throughout this pandemic, as we've been locked in our homes and really been reflecting on our lives, I think everybody can honestly say that this pandemic has been transformative for themselves and their families. But what I have found to be truly inspiring is how the scientific community around the world has really come together. And now, Dr. Vinh, you're part of an international group that is working together hand in hand to end this pandemic, and you're the only Canadian sitting on this group. So thank you so much for everything that you do and for your efforts. Can you tell us about this group and maybe some of the answers that you've begun to find?
Yes, absolutely. So as I mentioned before, my research program looks at understanding what is accounting for this variability between individuals in response to any given infection. So when COVID came around, it actually followed the same pattern. So we reoriented our lab research to understanding what was explaining the variability between individuals to COVID. Why were some people mildly symptomatic? Why were some people having life-threatening disease? As a result of my work, my previous work, I was already involved in a network of other experts who were studying those types of questions across the world. And when COVID struck, two of my previous collaborators, Dr. Jean-Laurent Casanova at the Rockefeller University and Dr. Helen Tsu at the NIH, where actually I previously trained for several years, they had contacted me and said, let's build this consortium. So there's this consortium called the Human Genetics Effort, so the COVID Human Genetic Efforts, COVID-HGE, which consists currently of about 85 clinician scientists from over 30 countries, and we're trying to understand severe COVID.
And have you found anything that would be of interest to our audience?
So even though this group has only been formed about 3 months ago, because of this concerted global effort for which we were able to contribute, we have actually found that faulty genes underlies about 10% of the severe COVID cases that we've analyzed so far. These genes are actually linked together functionally in a specific immune pathway. So why this finding is important is because it identifies unequivocally that this immune pathway is specific for COVID, and if it's weakened, people can get severe COVID. As well, in a different arm of our investigations, we've found that about 10% of people have severe COVID for non-genetic reasons, and those people, they actually have a molecule in their blood that neutralizes that same pathway that we found, in which we found the defective genes. So using these two approaches, what we found is that this pathway really is important for the ability of humans to fight off this virus, and if it's not working properly, you can get severe COVID. Now, that not only explains this variability between individuals for COVID, why some people have mild disease and why some people have severe disease, but it also gives us a glimpse into pathways that we can now rationally develop drug therapies to target and say, okay, how can we boost the immune system so that we fight off the virus and don't cause bystander damage in the process? And so now we will consider those clinical trials. Obviously, we need to study more patients. And I will be honest with you, we've contributed to some of that work, but it would be nice if we could do some of that same work that's being done at the Rockefeller and at the NIH here at the MUHC, because that way we've contributed this knowledge. How can we apply it here to help people in Montreal and in Quebec and Canada? Because we've we've contributed the knowledge. We want to be able to use that now new knowledge to help people here.
And it would be wonderful if some of these new drugs to be developed would actually be developed right here in Montreal to be benefiting our city, our province, and our healthcare.
It would be.
So thank you very much, Dr. Vinh. Dr. Naessens, I'd like to turn it over to you. You mentioned that immunosuppressant patients are not more at risk of severe COVID-19, but are they more at risk of catching the virus in the first place? And if so, how do they stay protected?
Mm-hmm. So I would actually, I'm thinking back to, again, the past few months, and we were actually very quick in our department to put all our patients who were considered immunosuppressed by virtue of certain medications or certain diseases, to have them work from home, avoid contacts with the exterior as much as possible, and basically have them do the general public health recommendations of social distancing early on, because the worry of the community at large was that perhaps these patients would be at higher risk of catching the disease, but if they were unlucky and would catch the disease, perhaps they would actually be more affected of severe disease than not. But the past few months, since we've put that in place, I've got to say we're somewhat happy to see that a lot of our patients did not get sick, either catching it, or few of them even were unlucky to catch it, yet they did not get sick to the point of needing intensive care unit. And in retrospect, we see that it's mostly patients who have medications for a transplant, whether it's a stem cell transplant or a solid organ transplant, or patients who have types of cancers, such as cancers of the blood or other malignancies, and who are on active chemotherapy. These two types of patients seem to be the ones who tend to be more severely ill if they do catch the COVID.
Dr. Naessens, can you explain to us how COVID-19 causes strokes? Because we're hearing a lot about sudden cases, and that seems to happen, at least from what we're reading in the media, happen a lot more to younger patients. So how does this happen? How does the virus cause that? So that's obviously a very concerning news that came out in the media recently. And this comes back originally from experience that was published back from New York City. And in New York, as you know, they were at a large point of pandemic earlier or later in the spring. And they actually reported 5 cases of young adults. They were below the age of 50 who did not seem to have cardiovascular risk factors, which we mentioned at first, such as high blood pressure, cholesterol, or weight increase. Yet these young patients presented to the hospital with an acute stroke, which refers back to an abnormal area of the brain where a vessel is occluded, often by a blood clot. And that's obviously of large concern because it can lead to significant complications for a young patient who was otherwise not known to be at risk of stroke. But let's remind ourselves that this is published data on 5 young patients. And we don't have much more data in a young population to truly document if we should all be worried about risk of stroke in a young population. And there are other risks of stroke in younger patients that should not be forgotten. And perhaps we need to keep that in mind, that we don't necessarily 100% relate this to a COVID infection. But you are right, it's a signal that we have to keep in mind. And I believe that the next few weeks or few months will probably guide us a little bit more to rates and whether there's risk factors or other concomitant diseases that would explain that in those young adults. But if we do look back again at the data that came back from China, we did see, and indeed you're right, a percentage of stroke in patients who were admitted with COVID. But these tend to be the older populations who had been hospitalized for some time already, and again, who were the ones who were sicker and had underlying risk factors. And these risk factors were inherent for their risk of stroke. And in fact, some of these patients already had a stroke in their lifetime. And if we think back also of previous diseases, even such as SARS or even influenza, we may think that the risk of stroke is slightly higher, again, in patients who are hospitalized. So we have to think of why this would be the case. And again, the medical community is not 100% clear on that aspect, but we probably have 2 different pathogenesis, so 2 different explanations. One of them is the amount of inflammation. So patients who are hospitalized with COVID,
we tend to see a marked elevation in their proteins in the blood that are our natural procoagulants, some proteins that regulate our ability to clot. And with inflammations, these are driven up, and it perhaps is one of the reasons why we're seeing some strokes. But there may also be another mechanism, and such as Don suggested earlier, that we have a protein called ACE2 that's present at the lining of the blood vessels. And whether this has an impact in the lining of the blood vessels in the brain, again, needs to be clarified. But this goes back to another observation that we had, and I actually have to say I saw it in real life in the spring. I saw a large number of new referrals for thrombosis. So these are blood clots in the legs or even blood clots in the vessels of the lung in patients who did not necessarily have had a history of blood clots, but were hospitalized with severe COVID. And we are seeing more reports of blood clots. And again, the literature does seem to confirm that, but the rate is very wide according to which data we're looking at. But we're certainly concerned enough that there are some ongoing research trial looking at what's the best way to prevent the occurrence of blood clot in patients who are hospitalized with COVID and even those who are discharged home.
So there was a study published recently that indicated that people with an A+ blood type were more at risk of blood clots and strokes. And everyone I know is now getting checked to find out what blood type they have. Is this a real indicator for severe COVID?
Right. This actually came back from initially an observation, again, from China, but there was a large study that was published, came out of Europe, looking at patients from Italy and Spain, whereby they looked at the genomes of patients who were admitted in the intensive care setting versus those that were not, so that were seen to have, quote unquote, milder disease. And they seemed to see that patients who were of group A were more likely to be in the severe group than patients who were in the group O. So that struck a bit of that observation. Is the blood group something that would be prognostic? Does it have an impact in the severity? But we have to think back that the blood group per se refers to the protein, so the antigen that we have at the level of the red cell. But this also is something that we see as per different populations. So let's say in China, or let's say in parts of Europe, close to the Mediterranean, then we may see specific blood groups that are more prevalent in that area. And perhaps it does not necessarily reflect something specific for the blood group, but rather sort of an ethnic propensity or other genetic factors that we yet have to find. And I'm sure that Don with the international group may be helpful, maybe finding something in the future apart in terms of that. But there's a subsequent and in fact much larger study that was published from the United States, and it had about 8,000 patients. And this discredited the idea that blood group A patients are sicker than blood group O, because they actually did see a similar amount in a blood group in different types of severe patients with COVID. So I don't believe that your blood group is a prognostic indicator of how sick you may get if you do catch COVID, whether if you're blood group O or not, whether you're at lower risk of catching the COVID, that's a different story, and that yet has to be clarified.
Dr. Vinh, these are all great indicators, but what does that really mean for patients? I mean, I'm hearing all of this, and that makes me worried now. I'm thinking, what are my genes? What are my blood type? And how can I stay better protected? What is your advice to the community in staying protected with the knowledge that we have today about COVID-19?
So I think Vero very much illustrated a very nice point, which is that there's a lot of data that's coming out. And the data, we are trying to absorb it as a medical community, digest it, and then translate it into how we can impact patient care. But it continuously changes, not because the science is bad, but because the science moves so quickly. And so what we're trying to do is, how do you implement the care? On the other hand, we don't want for the public to be too overly worried about it. What we're trying to do is we're trying to implement this in a rational manner. I would not recommend that people go out and get their blood test tested, and I would not recommend people go out to do genetic testing and that kind of stuff. We're not there yet. we want to be there. We will get there at a point where we will be able to have robust markers that says if we can measure these different markers and use specific computer algorithms, then we can figure out what trajectory every person will have or what likely trajectory every person will have once they get COVID.
But you're working on research on a day-to-day basis. How does that get, and how does this immense amount of information that is flowing from all over the world, how does that get translated into the hospital in the clinical areas?
So we are getting bombarded with sort of new updates of information and new articles and articles that are not even published yet, but that are pre-printed. We collectively meet as a group of infectious disease specialists, as a medical microbiologist, and as researchers to figure out exactly how do we implement the next step. Is this a valuable piece of information that can be translated to patient care, especially our patients? And if so, how do we do that? Do we do that through clinical trials? Do we do that through projects? So we are quite active here at the MUHC on this.
Dr. Vinh, schools have reopened across the country, and how do we stay safe? And should we be concerned as parents and as grandparents about the reopening of schools?
Well, I certainly think that we have a new normal, and we probably need to have a stronger concern now than before the COVID pandemic about this aspect of public deconfinement, which is the return to school. On the other hand, we also have to remember that the school system is incredibly important for the development, socially, personally, intellectually, et cetera, for children. And while there certainly can be some of this accomplished online, for example, there really is no substitute for the school system, which necessarily involves being together with other children of your age to be able to play, to learn, and to learn from teachers. So what I think we need to do is balance those two. And as a result of that, public health measures have to be put in place and have to be adhered to, where we have to try to maximize the benefits of the school system and minimize the potential not only for children to potentially get infected with each other, but also children infecting adults, adults infecting children inside the classroom and also at home. So I think it can be done. I think it will need to be done because the virus is not going away, but we will need to ensure that all aspects of public health measures are adhered to inside and outside of the school for this trial of go back to school to work.
But now you worked with, because you have 5 children, Dr. Vinh.
4 that I'm aware of.
4. That's a lot of children.
Yes. Some days they're more than I can handle.
Now, you've worked with your children's school to implement a plan. Now, unfortunately, not all schools have a Dr. Vinh to help them implement such a plan. But can you tell us some of the elements and components that you've included in that plan?
Yes. So one of my children, he's in middle school, and that school has actually, I've been working with. They've actually approached me now several months ago, and I've been working with them to roll out different measures in place. Some of it also is because the policies have changed a little bit from the government, but certainly all aspects of public health measures inside the school we've looked at. We've looked at ventilation systems, either portable or renovations if necessary of classrooms. We've talked about trafficking of direction of students as they go from one place to the other. We've talked about hand hygiene. We've talked about toilet hygiene and bathroom hygiene inside the school. We've talked about measures to isolate children who may be symptomatic and what are the measures to put in place if there's a concern that a child may have symptoms. Same thing for the staff. So there's a lot of aspects that need to be addressed. They need to be planned. They need to be beta tested. They need to be adaptable. And I have been working with my school, and I certainly hope that other schools will have a similar type of guidance.
Well, I certainly hope that the Minister of Education is listening today and is going to take, or at least ask for some advice on that. As parents, we're always concerned. I have 2 children, and since they've started daycare, I think we have constantly been bombarded with panic of lice and foot and mouth disease and all types of viruses I had never heard of until I had children. But with the pandemic still ongoing, because the vaccine is not going to be available in the coming months, should we be keeping our children away from their grandparents during the period as they're going back to school? Should we be isolating them away from the community?
I don't think we should be letting them go back to school, but isolating them from the rest of the community. I think it's a bit contradictory. On the other hand, we also cannot be carefree in letting these interactions occur either. As we know, there are some children who visit their grandparents. There's some children who live with their grandparents, and not all grandparents have, are pictures of perfect health, and not all of them have multiple health problems. So it's a little bit hard to give a generic approach. Certainly, if you live with somebody who has a risk for getting the severe forms of COVID, as we talked about, I think we have to be a little bit more vigilant, perhaps more adherent to public health, more strictly adherent to the public health recommendations, and in some situations, maybe even consider minimizing some of these activities, perhaps going to the educational activities and minimizing athletic activities or social gathering activities. So I think we have to be able to tailor it based to the individual family's needs.
Dr. Naessens, we are seeing a lot of nonsense coming out, and I have to call it nonsense, coming out of the United States about anti-maskers who are refusing. And we've all seen some YouTube videos, even from Quebecers who are refusing to wear the mask. Why is it important? I mean, we've seen a lot of flip-flopping. In the beginning, we didn't need to wear a mask, and now masks are mandatory in Quebec and highly recommended across North America. How do you explain that?
So you're right that you're using the word flip-flopping, and not that long ago, the rules changed quite a bit, wearing a mask, not wearing a mask. So it probably led to a bit of confusion and maybe a bit of mistrust in certain types of population or a few persons. But the reality stays the same. The goal of the mask is to prevent us from transmitting the disease to someone else. And as we already said, the scientific discovery and knowledge in COVID is evolving so rapidly, and so are the public health recommendations because of that. So initially, we said that if someone is symptomatic, is unwell, well, they should be at home and stay isolated, and they shouldn't be going out, even if they're trying to stay safe. They should just stay isolated at home. But in fact, we now have discovered that patients can still transmit COVID-19 if they are asymptomatic. It means that they don't even know they have COVID, they don't have any symptoms. And that's the reason why wearing a mask is extremely important, because if we are asymptomatic, we could still be at risk of transmitting the disease to someone else. And God forbid, someone who would be at high risk and who would be severely sick. So I believe it's extremely important to wear the mask as recommended by public health, along with their recommendations.
Dr. Vinh, if I've bought a reusable material mask, do I need to clean it twice a day? How does that work?
So that's a great question, and we certainly don't have the time to go into, but there are different kinds of masks. There are masks that we use in the healthcare system, and there are masks that people make at home. Even if you make those at home, there are still some recommendations that are being made, for example, by the CDC. So what you don't want is a used underwear on your face. That's not going to be protective. You certainly need to have some types of materials and different layers of materials to be able to provide you some level of protection. So I think we have to be cognizant of the fact that if you're going to do your own mask, follow the government recommendations that are out there, or you can buy yourself a certified healthcare worker type of mask.
Fantastic. Well, Dr. Don Vinh, Dr. Veronique Naessens, thank you so much for joining us. You can visit muhcfoundation.com to ask your questions and also to find out more about next week's episode. Thank you so much for listening, and stay healthy.